Hello everyone. We are doing the chapter 15, infection and immunity, from illustrated textbook of pediatrics, continuing with the topic of tuberculosis. If TB is suspected, a tuberculin skin test, also called Mantoux test, is performed by injecting purified protein derivative of tuberculin into the forearm 2 units intradermal injection right after 48 hours to 72 hours as in duration measured in millimeters because purified protein derivatives is a mixture of proteins, some of which are expressed by both MTB and BCG, which is the taste immune positive because of the past BCG vaccination rather than TB infection. Most international guidelines therefore suggest that a history of BCG measures should be taken into account when interpreting the test results. So UK recommendations deviate from this nice message of healthcare excellence guidance suggest an incubation of 5 mm or more should be considered to be positive regardless of prior BCG vaccination. Other countries use different cutoffs, typically 10 mm. Interferon gamma releases as a IGRAs and newer blood-based tests for TB. This is the response of T cells to in vitro stimulation with a small number of antigen expressed by M tuberculosis but not by BCG. Also results of when we get TB infection rather than BCG vaccination. However, negative IGRA results does not reliably rule out a TB infection. Also, there is increasing evidence that IGRAs perform worse in children compared with adults. Neither IGRA or the TST context relationship relating TB and active TB so correlation with clinical signs and post required as 20% children with TB disease have a negative TST or IGRA. However, decision to treat is made on clinical and microbiological assessment, and TB should not be excluded in a child with a negative immunoassay. Co-infection with HIV makes the diagnosis even more difficult. With advanced immunocompromise and malnutrition, both TSC and IgRA can be false negative. Contact history, radiology, and possible tissue diagnosis become even more important. One must avoid making an incorrect diagnosis of TB in just X-ray appearance alone, as lymphoid interstitial pneumonitis can have a similar appearance that occurs in 20% of HIV-infected children. In view of the overlapping epidemiology, all individuals with TB should be tested for HIV and vice versa. Treatment, quadruple therapy, rifampicin, isoniazid, pyrazinamide, and thiambutal is recommended national combination unless MD or TB is strongly suspected when a household member has been recently diagnosed with MD or TB. This is decreased to rifampicin isoniazid alone for after 2 months, by which time antibiotic sensitivity are often known. Fixed dose combination drugs are available, particularly for ovulation and adolescent. These can reduce overall pill burden and improve compliance, but there is an urgent need for more child-friendly drug preparations to improve adherence in young children. Treatment for uncomplicated primary TB lymphadenitis is usually for 6 months. Longer treatment courses are required for osteoarticular TB meningitis, or disseminated disease. Compliance is crucial. Families and young people can be supported in a number of ways in the community, including direct observed therapy, dots, and video observed therapy, dots and watts. In adolescents, pyridoxine is given weekly to prevent peripheral neuropathy associated with isoniazid therapy, a complication that does not occur in young children. TB, meningitis, dexamethasone given initially to decrease the risk of long-term sequelae. Asymptomatic children who are monocytes or IgRA positive and therefore latently infected should also be treated with rifampicin as soon as 3 months or isoniazid alone for 6 months, as this will decrease the risk for reactivation, that is conversion to active TB later in life. They should be treated with asymptomatic should be treated with rifampicin isoniazid 3 months or isoniazid alone for 6 months. Prevention and contact tracing. BCG medicine is shown to reduce incidence of TB, but its protective effect is incomplete. The BCG vaccinated children can still acquire TB infection. In the UK, BCG is recommended for high-risk groups only and is not given freely to any age group. BCG, which is live vaccine, should not be given to HIV positive other than immunocompromised children due to risk of severe local reaction dissemination. BCG can cause a local reaction, often forming a blister with surrounding erythema 2 to 6 weeks after the infection. This can ooze and scab. This is normal and will resolve. BCG can also cause non-suppurative suppurative lymphadenitis. Non-suppurative lymphadenitis will resolve without vision treatment. The optimal management of suppurative lymphadenitis is unclear. And meanwhile, aspiration, surgical excision, medical management, or wash and wait. As most people infected by household contact, essentially screen other family members for TB infection. Children were exposed to individuals with uh, pulmonary TB should be assessed for evidence of latent TB by TST-IgRA. Children under 2 years who had close contact with victims were positive pulmonary TB. Persons should be started in polyphylactic anti-TBs because the risk of infection progress to disease is high at this stage, and the immunoassays are least reliable in this age group. The next one is non-tuberculous mycobacterium infections. These are numerous non-tuberculous mycobacteria found in the environment in immunocompetent which is really subclinical disease caused by these organisms. They occasionally cause persistent lymphadenopathy in children who are otherwise well, primarily affecting the cervicofacial region. The skin overlying the node often becomes violaceous and thin, where technically possible without risk of damage to the facial nerve. The most commonly used treatment approach is complete lymph node excision by biopsy or partition can result in formation of a chronic fistula and poor healing. Alternative treatment approaches are watchful waiting. No intervention as in the majority of cases. Spontaneous resolution occurs over several months of treatment with antibiotic microbacterial antibiotics. Unlike TB, these are transmitted by soil and water and therefore contact tracing is not required. Non-tuberculous TB mycobacterium may cause disseminated infection. Immunocompromised mycobacterium, avian intestinal infections are particularly common in patients with advanced HIV disease. These infections do not respond to conventional TB treatment and require a combination regimen of different antimicrobacterial drugs. Recently, chronic pulmonary non-TB mycobacterium infections have become an increasing problem in those in with cystic fibrosis. Treatment of these infections often occur only successful in some instances. TB reflects in summary, it affects millions of children are very low but increasing incident in many high-income countries. Clinical features follow sequence. Primary infection, the latency, which may be followed by conversion to active TB months to years later. Diagnosis is often difficult, so decision to treat is then regional quantum history, tuberculosis skin test, and metaphoric gamma release assay results, and extra findings and clinical feature. Against drug therapy can be problematic but essential for successful treatment. Contact tracing and identification children with latent TB are important. TB is more difficult to diagnose and more likely to disseminate in immunocompromised individuals. Now, the tropical infection. The tropical infection must be considered most febrile children who have a recent travel history to a tropical region have a non-tropical infection. For example, a common viral infection, the common or most is imported infections are outlined. A febrile child returning from the tropics, most common causes are non-tropical infection. We consider malaria and typhoid fever as well as other tropical infection. Approach to a febrile child returning from the tropics. All places based on duration of stay, immunization, malaria prophylaxis, history of food, drink, infected water, accommodation exposed to insect vectors, infectious contact from TB, swimming, infested rivers and lakes, particular reference to fever, jaundice, anemia, and large liver spleen. That is examination. Non-tropical causes of fever. Consider non-tropical causes of fever in childhood, upper and lower respiratory tract infection, GIT, UTI, septicemia, meningitis, osteomyelitis, and hepatitis. Tropical infections are malaria, typhoid, viral infection transmitted by mosquitoes, gastroenteritis, and dysentery, and violent hemorrhagic fevers. Malaria has 40% population live in an area where female anopheles transmits Anopheles mosquito transmissible malaria causes over 250,000 child deaths in South Africa each year, mainly from transmitted falciparum malaria. The clinical features include fever, often not cyclical, diarrhea, vomiting, flu-like symptoms, jaundice, anemia, and thrombocytopenia, while typically the onset is 7 to 10 days after inoculation. Insects can present months later. Infection can present months later, depending on the Plasmodium species. Children are particularly susceptible to severe pneumocerebral malaria. Diagnosis by examination of thick blood films. The species Falciparum vivax, ovarian malaria, and nerve is confirmed on thin blood film. Repeated blood films may be necessary. Rapid diagnostic tests. DTs can also be used to establish the diagnosis. Plasmodium falciparum treated with quinine and um, artemisinin and waste formulation, and travelers to endemic areas should seek up-to-date information on malaria prevention. Prophylaxis reduces but does not eliminate the risk of infection. Prevention of mosquito bites with repellents and red nets is also important. In many countries, there has been a marked reduction in the incidence of malaria in children from insecticide-treated bed nets. Indoor residual spraying of houses with insecticides, destruction of mosquitoes, larvae, and breeding areas, and prompt treatment with artemisinin-based combination therapy. And next is typhoid, child worsening fever, headaches, cough, abdominal pain, anorexia, malaise, myalgia, may be suffering from infection with salmonella typhi, paratyphi, GI symptoms, diarrhea, constipation may not appear until the second week. Sputum very bradycardia, rose color spots on the trunk may be present. Serious complications of disease include GIT perforation, myocarditis, hepatitis, and nephritis. Right. The recent increase in multi-drug resistance strains, particularly from the Indian subcontinent, means that treatment with cotrimoxazole, chloramphenicol, and penicillin is often inadequate. A third generation cephalosporin, or as azithromycin, is usually effective. The viral infections Plasmodium and mosquitoes, dengue fever widespread in the tropics. The primary infections characterized by a fine edematous rash, nausea, arthralgia, and high fever. After resolution of the fever, secondary rash with dissemination may occur. Dengue hemorrhagic fever, dengue shock syndrome occurs when the previously infected child has a subsequent infection with a different strain of the virus. The partially effective host immune response augments the severity of infection, causing severe capillary leak syndrome, leading to hypotension as well as hemorrhagic manifestation, include resuscitation, mission, and recovery. Chikungunya is endemic in parts of Africa, Asia, and India, and children can cause fever, arthritis. Zika virus is usually transmitted by Aedes mosquitoes, mainly Central and South Asia and the Caribbean. In children, it may cause fever, rash, conjunctivitis, and arthralgia in pregnancy associated with fetal microcephaly and other abnormalities, brain abnormalities. GIT and dysentery gastroenteritis frequently accompanying foreign travelers. Diarrhea is travelers' diarrhea is commonly caused by change in gut flora, viruses including rotavirus and coli. It really needs more than attention to dehydration. Fever accompanied by loose stools with blood or mucus suggests dysentery caused by Shigella salmonella, Campylobacter, and Enterobius blood cultures and stool cultures should be taken and appropriate antibiotics are indicated. Viral hemorrhagic fever causing increased Lassa, Marburg, Ebola, and human Congo virus. These are infections are imported, are highly contagious, and have a high mortality. If suspected, strict isolation procedures should be initiated for any symptomatic patient who has returned from an endemic area within the 21-day incubation period of these infections. Specialist advice should be sought. Now, with HIV infection could be there are over 2.8 million children and adolescents living with HIV infection, mostly in the sub-Saharan Africa. Though there has been decline in number of children becoming infected each year, there was still an estimate of 160,000 new infection children under 14 years in 2018. There are around 15 million children who have lost a parent to HIV-related causes. The major root of HIV infection in children is mother-to-child transmission, which occurs during pregnancy, delivery, and delivery postpartum or through breastfeeding postpartum. The virus can also be transmitted to children hydrogenetically. As hydrogenically as a result of lapses in infection prevention and control, IPC measures such as by infected blood products or contaminated needles or through sexual abuse. Diagnosed in children over 18 months of age, HIV is diagnosed by detecting antibodies against the virus. Children less than 18 months of age who are born to infected mothers will have transplacental maternal IgG HIV antibody. Therefore, this is positive antibody test confirms HIV exposure, but not HIV infection. Most sensitive tests for HIV diagnosis before 18 months of age is HIV DNA PCR. When internationally, the most commonly used is the viral load assay, which measures RNA copies per ml. All infants born to HIV infected mothers should be tested for HIV infection, whether or not they're symptomatic. At first, a first test for evidence of any in-utero infections undertaken at birth, establishing that the infant is unaffected, then relies on at least two further negative tests for the viral genome, HIV DNA, or RNA PCR, after cessation of post-exposure prophylaxis antiretroviral ART. This is confirmed by the loss of maternal HIV immunity from the infant circulation after 18 months of age. Now, the clinical features without treatment, about 20% of HIV infected infants progress rapidly to symptomatic disease and onset of acquired immune deficiency syndrome, AIDS in the first year of life. However, other affected children remain asymptomatic for months or even years before progressing to clinical disease. Some asymptomatic children are only identified in adolescents at routine screening following diagnosis and other family member. Clinical presentation varies with degree of immunocompromise. Children with mild immunocompromise may only have lymphadenopathy protein large, if moderate, they may have recurrent bacterial infections, candidiasis, chronic diarrhea, or lymphocytic interstitial pneumonitis. This lymphocytic infiltration of the lungs may be caused by a response to HIV infection itself, or it may be related to EBV infection. Severe AIDS diagnoses include opportunistic infection, pneumocystic gyri, carinine pneumonia, PCP, severe growth faltering, encephalopathy, and malignancy, although the latter were rare in untreated children who tended to die of other causes before developing malignancy. More than one clinical feature is often present, an unusual constellation of symptoms, especially if infection should alert one to the possibility of HIV infections. Now, this is the lymphocytic interstitial pneumonitis children with HIV infection. This is diffuse reticulomedullary shadowing with higher lymphadenopathy. The one is CT scan, which is encephalopathy showing diffuse increase in cerebrospinal fluid spaces from cerebral atrophy and volume loss. Bullet point is children with persistent lymphadenopathy, paracytomia, recurrent fever, barotraceous swelling, thrombocytopenia, initiation, serious persistent unusual recurrent infection should be tested with HIV. Treatment is common and antiretroviral therapy and should be started in all children regardless of CD4 count once the diagnosis of HIV has been confirmed. As an adult, combination of 3 or 4 drugs are used prophylaxis against PCP with cotrimoxazole prescribed for infants who are HIV infected and for older patients with children with low sleep count. Other aspects of management include immunization, which is important because of higher risk of infection and should follow the routine vaccination schedule with the exception of BCG. The BCG should not be given as it is live vaccine and may cause disseminated disease. Vaccination against influenza, Hep A and B, and VZV should be considered. Vaccination against influenza, Hep A, B, and VZV. Varicella zoster. Multidisciplinary management of children, if possible, in a family clinic when they they can be seen together with other members of the family, which may be HIV infection, where the team includes an adult. Especially, the team will need to address issues such as adherence to medication, disclosure of HIV, diagnosis planning for the future, regular follow up with particular attention paid to weight, developmental progress, and clinical signs and symptoms of disease. Effective ART has transformed HIV infection into chronic disease with the vast majority of perinatally infected children surviving into adulthood. Some HIV clinics in the UK increasingly manage donors and young adults, providing services to address issues such as difficulties with adherence, stigma, safe sex practices, fertility, and pregnancy. Reduction of vertical transmission. Mothers who are most likely to transmit HIV to their infants are those with a high HIV viral load and most more advanced diseases when mothers are not taking ART and breast feed. 25 to 40% of infants become infected with HIV. Avoidance of breastfeeding reduces risk of transmission by about 4% for every 6 months and a child is breastfed. In high income countries, perinatal transmission of HIV is reduced to less than 1% by using a combination of intervention, use of effective ART during pregnancy and intrapartum to achieve an undetectable maternal viral load at the time of delivery, versus social prophylactics with ART given to the infant by 2 to 4 weeks after birth, avoidance of breastfeeding, active management of labor and delivery to avoid prolonged rupture of the membranes and unnecessary instrumentation that is forceps. The brain Pre-level section if the mother's viral load is detectable close to the expected date of delivery in low and middle income country. WHO recommends lifelong aid for all pregnant women with HIV infection, whatever their CD4 count, and they exclusively breastfed their babies for the first 6 months before weaning and continue to breastfeed as long as they wish until 24 months. AIT as post-exposure prophylaxis should be given to newborn with a breast formula for the first 4 weeks of life. Bullet point is anti-lethal antiretroviral treatment, active management of event delivery, and avoidance of breastfeeding can reduce the vertical transmission rate of HIV to less than 1%. Now, the summary HIV that 2.8 million children worldwide infected with HIV, which are less than 15 years. Treatment includes a combination ART, prophylaxis against cystic shy pneumonia, and the majority of perinatal infection children are surviving into adulthood if ART is available and ART raises complex psychosocial issues for the family and healthcare providers, including when and what to tell the HIV child and the sometimes confidentiality and adherence support. So the next one is Lyme disease. This disease called bacterium Borrelia burgdorferi and was first recognized in cluster of children with arthritis in Lyme. Electrical. It also occurs in the UK and other European countries, part of Asia and North America. Borrelia burgdorferi is transmitted by heartbeats, which have a range of foods, including sheep, foxes, and small mammals, including hedgehog, including in only half. However, in only half of the cases, there is a history of preceding big bite and thus most ticks attached to the legs. But in children, there was questioning. Ticks tend to be the top of the long grasses. They may attach anywhere, including in the hairline. Infection occurs most commonly from June to September, but can occur throughout the year. Tick population are expanding their habitats, mostly due to climate change and land management. These are found on the edge of woods and any grassy areas, including in urban parks. Travel history, particularly to Central and Eastern Europe and Northeastern, say the USA should be elicited. And clinical feature following an incubation period of 4 days to 30 days, and epidermis microwave at the site of tick bite, largest to cause a classical cell lesion known as erythema migrans, a plumous red expanding lesion with a bright red outer spreading edge. It is not usually itchy. During early disease, this condition may be accompanied by fever, headache, malaise, myalgia, arthralgia, and lymphadenopathy. Usually, these features fluctuate over several weeks and then resolve. Influenza-like symptoms outside the flu season should prompt suspicion. Dissemination of infection and the in the early dissemination infection in the early stages is rare, but will lead to cranial nerve palsies, particularly facial nerve meningitis, arthritis, and carditis.